I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Hello, and welcome to this episode of the IDD Health Matters podcast. My guest today is Dr. Angeline Stanislaus with the Department of Mental Health. She's the Chief Medical Officer in Missouri. Welcome.
Thank you for having me.
So let's just start by talking about what you do in this field and the work that you do in Missouri.
So in Missouri, I was hired as the Chief Medical Officer for the Department of Mental Health in 2014.
Okay.
At that time, my main work at the time was working with our state psychiatric population. We had a sex offender population as well within the Department of Mental Health, which I was mainly working with and developing programs. After COVID, around 2022, I was noticing a lot of individuals who had intellectual disability who are actually boarded in an ER and are psychiatric hospitals.
That's a problem we hear about more than we want to hear about, I will say.
Absolutely. I would get phone calls from the hospital association, from my staff, from hospitals, very, very angry, extremely angry, and saying this person has no other problems, all their problems are due to intellectual disability, and they are taking out a whole ward, and we do not know how to manage them, and we don't have to manage them, we don't have to treat them, you just need to come and get them out. This then, and I would sit for hours, I'm talking about an average 5 to 6 hours a week on these phone calls.
Wow.
And it was just not me, it was also my staff.
Mm-hmm.
And one day I looked at the number of people who are on this staff, and they were at least 8 to 10 people, and they were the same people who would come from every meeting, week after week. And I would think, we are spending close to $1,000 on one of these meetings for my staff time.
Sure.
And what are we getting in return? And the other thing, what I noticed was, and there was no outcome. It was not like it was productive. I had some solution to solve, or a problem to solve, or a solution that I could create. It was solutionless time consumption of a group of professionals. And that's when I realized there should be a better way to deal with the problem. And that's what really got me into the intellectual disability and mental illness field, to really look at it from a statewide perspective, from a national perspective, and really become more focused on developing a solution.
Well, I'm very excited to hear about what you've worked on and what you've developed to help with some of those issues, and because I know it's something that a lot of people face throughout the country who work in this field. So tell me more.
So one of the things we identified was that there were providers who were more trained in the intellectual field, so they knew how to take care of people with intellectual disabilities, but they did not know that when there is a co-occurring mental illness, what needs to be done and how to manage them. There are usually only two major solutions they did, two main things. They either call the cops or they dropped them off in the ER and gave a 30-day notice. And both are not the outcome.
Absolutely not.
And this then led me to think, this is how a lot of those individuals with intellectual disability ended up in the prison that I had treated 10 years earlier. So this was the upstream that the intervention needs to happen in order to prevent those with intellectual disability not ending up in prisons.
Sure.
Because they have an undiagnosed, untreated mental illness.
And we know that people with intellectual and developmental disabilities do have a higher incidence of mental health conditions, co-occurring mental health conditions, right?
Absolutely. Yeah. I just attended the conference here at NASDAQ, and the National Core Indicator shows that 49% of individuals with intellectual disability and autism spectrum disorder have a co-occurring mental illness.
That's pretty significant.
That's a high number. That's half.
Yes.
That's a half the population, and yet we don't have good systems of care to provide care for these individuals.
Sure. So what types of things did you develop or put in place that you found to be helpful?
So there were several things. One, we found a gap between systems of care. We have the intellectual disability system of care, and you have a mental health system of care. So you have a mental health system, you have intellectual disability system, and often there's no bridge in between.
Yes, and that speaks heavily to the need and importance of integrated care, integrating mental health care with physical health care, and I'll throw in oral health care as well too, because all of these things are very interrelated, and one often affects the other.
Absolutely. Yeah. And it's in the same person.
That's right.
The systems are different, but they're all occurring in the same person. Maybe physical health, oral health, and mental health all are in the same person, and the person who's prone for one is prone for the others. Mm-hmm. For example, if you have a mental illness and you are on a lot of psychotropic medication that can dry you out, that can cause constipation, that can cause oral health.
And constipation can cause adverse behaviors and challenging situations that could be due to a treatable underlying cause. I'm so glad you brought that up, because it's something I talk about a lot. And so often we see a person that's having a challenging behavior. Maybe they're aggressive towards others, they're aggressive towards themselves, and we need to figure out what the underlying cause is and not make an assumption it's one or the other.
Exactly.
We shouldn't assume it's always a mental health condition. We should make sure it's not a physical health condition that's causing these symptoms. And you mentioned medications. Okay, this is great. Keep on going.
Yes, so what we realized is that we do not have an integrated model of care. It was a very siloed, fragmented system of care. The other issue also is that I'm a psychiatrist. I looked at a residency program. I probably got about a month of visiting 1 day a week, so that's 4 visits to a HAB center in Illinois when I trained in Illinois.
And that's honestly probably more than a lot of physicians get.
That is correct.
Yes.
Because at least the program I were trained in, they had a relationship with the HAB center. And that is not enough.
No, it certainly is not.
Absolutely not enough. So there's no exposure. Even those psychiatrists who go through a 4-year psychiatric residency program in this country, to have any exposure or understanding of issues that occur in those with intellectual disability.
Yes, and that's true for all health professions. Unfortunately, we simply aren't trained to understand and to recognize and to meet the healthcare needs that people with intellectual and developmental disabilities have. And I often talk about it in a way, it's not that the condition itself is unusual. We might see something more frequently like aspiration or constipation, but it's connecting the dots and recognizing the different ways that these conditions present in someone who isn't necessarily able to tell you exactly what they're feeling in their body, or they don't use words to communicate. And that really is, I think, on us as clinicians, is we need to be trained to understand and recognize these different presentations of these illnesses so that we make better diagnoses and treat the root cause of whatever the situation is, and not just saying, hey, well, this person does this because they have an intellectual disability.
Absolutely. Yeah. And that is the point. So when they go see psychiatrists or board certified psychiatrists, who are pretty good psychiatrists when it comes to those with neurotypical individuals, when they look at individuals with intellectual disability, their brain shuts off and says, I don't know what's going on with this person. I don't know if this behavior is coming from intellectual disability. Is there a psychiatric diagnosis? And how do I diagnose psychiatrically with confidence in a person with intellectual disability? So there is a lot of lack of competence, of feeling. I don't think they're really incompetent. I just think they believe they're incompetent, or they do not want to put in the time and effort to look and understand what is going on. with the patient in front of them.
I can see that. That makes sense. Yeah.
And so many times it is not that they have not gone to a psychiatric clinic or to see a psychiatrist or gone to the mental health system for care. It is often they have not received optimum level of care that they need to get their mental illness under control, to get a state of remission, and so they can live fulfilling lives.
And the way that I see that is it really does relate directly to education and the importance of educating clinicians. And I don't think it's that the clinicians don't care either. I think it's just they're not sure what to do. And I use this example sometimes. I'm a family doctor. If you came to see me for cataract surgery, I would either refuse to see you because I'm not comfortable, or if I had to see you and I wasn't trained to do it, it wouldn't go very well. You would go blind. Not because I don't care, but because it's not something I was trained on. And cataract surgery or things like that, they're specific and you do need specific training. But all healthcare providers see people with intellectual and developmental disabilities, whether they recognize it or not.
That is the key. The moment they know that the person has intellectual disability, something shifts. But there are so many clients that they treat not knowing they have intellectual disability.
Yeah.
And once they hear that they have intellectual disability, they suddenly feel like maybe there's a specialist out there. And the truth is, there are no specialists. We are it.
Yes, and most of us have learned through our own experiences or learned it the hard way. It's the way I learned it. When I first began working in this field in the 90s, I had that same feeling of, oh my gosh, I'm not really sure how to evaluate this person. They can't tell me symptoms the same way someone else does. What do I do? And I learned it from the clinicians, the nurses primarily, who had been working in the field for many years, and they learned it the same way.
Exactly.
And we're actually, we've actually lost that pathway for clinicians to get that training as we have more people living in community settings, which is great that they're in community settings, but where can clinicians get that type of training? If it's not in their residency programs, if it's not in their medical schools, I think we as a healthcare system need to ensure that they get this training somewhere.
I fully agree. Even if you go to one of our main conferences like American Medical Association or American Psychiatric Association, there is not a track for intellectual disability.
Yes.
And we have to go for very specialized conferences like the AADMD or other like NASDAS, other places specifically to learn more. In Missouri, what we have done over the last 2-3 years is incorporate an intellectual disability track to all our major conferences.
That's fantastic. That's great. I talk about this, and it's what I did in the beginning. When I first learned that we need to train our healthcare providers, especially as more people were moving into community settings out of larger institutions, I had to basically force my way into regular healthcare conferences. And I got pushback because sometimes they said, why do we need to learn this? We don't really need to learn this. And I'll say, just let me come do one talk. And I would do a talk and people were like, oh my gosh, I never really realized these things. Would you come back next year? I'm like, yes, I would. And thank you for giving me the opportunity. But that is a part of the problem. We don't know what we don't know sometimes.
Exactly.
We don't know that we need to know these things.
Exactly.
So part of it is just helping people recognize, wait, this is important, it's valuable. You need to spend some time learning about it, and whether it's in your training programs or in your continuing medical education opportunities. But those weren't there years ago, and there's more. Would you agree that there's a little more emphasis now?
There is more opportunity, and the thing is that it's that we as professionals, you, I, people like us, just have to champion it.
That's exactly right.
We just have to champion it. We just have to bulldoze our way into these conferences and talk about it, because we cannot continue to ignore it when autism spectrum disorder rate is 1 in 36.
Yes. Yes.
That is a very high rate.
Yes.
And you cannot just ignore it.
No.
Because think about it, moving forward, another 20 years, every medical professional is going to see individuals with autism spectrum disorder and with intellectual disability, whether they like it or not.
A family physician patient panel is it varies, but somewhere around maybe 2,000 people or so. 1 in 36, that's a lot of people with autism spectrum disorder that they will have in their patient panels. So we need to learn about this. You need to learn about this.
That is correct.
And I also encourage people, I love what you did by bringing it into the non-IDD conferences. And that's something I work to do as well too, because I find, when we work in this field, we all understand these things, but often we're talking to people who work in this field.
Yes.
So we've got to force our way, advocate, be a champion for getting these types of talks, these lectures at conferences into non-IDD focused conferences, because that's where people need to hear it.
Absolutely.
Yeah. I've had a little success doing that as well. I've had the opportunity to speak at the American Academy of Family Physicians Conference a couple of times. And the first time I spoke, there weren't very many people there. When I went back 2 years later, I had 10 times the number of people. I went from about 25 people to about 250 people in the session, which told me a lot. It's like people are starting to recognize, oh, I need to hear about this. I need to learn about it. So it's what we're doing and advocating. It is helping.
It is,
I think.
definitely.
So, yeah. So when you've, or what kind of outcomes have you seen in Missouri as you've begun implementing this training or helping people understand some of the ways that people with IDD might communicate health conditions or mental health conditions differently? Have you seen some?
We are still working on that. It's an ongoing. We now have started like trauma-informed care training in Missouri. I probably speak maybe 2-3 times a month to different organizations, different communities about how to identify mental health conditions in those with intellectual disability and how to access care.
Mm-hmm.
And the more I speak, the more requests I get. And so I'm connecting the dots. It's slow, but I can really see that momentum. And I would say a good 25% of my time is actually dedicated now to training and education.
I like what you said. The more you speak, the more requests you get, because people start to realize, wow, I need this training. I need this information. Yeah, that's great.
So that one thing I do. I'm also part of ECHO. I serve as a hub team members, an expert panel member, and ECHO.
Let's just talk about that to make sure everybody knows what an ECHO model or an ECHO project is. Basically, they call it a hub and spoke model, where you have a team of an interdisciplinary team. It's not all medical. There might be a social worker, a mental health professional, a physician, a family member with experience, and they kind of facilitate a meeting with other clinicians that are maybe in more rural parts of the state that don't have access to or it's more challenging for patients to be able to access clinicians. And you meet, there's a little didactic where you talk for maybe 15 minutes about a particular topic, and then you present a case that comes from one of the spoke people, and you talk about it, and everybody learns from it, including people on the hub.
Absolutely.
We all learn from it, and it's a fantastic model. It's not specific to intellectual and developmental disabilities. No. I think it started in, was it New Mexico?
It started in New Mexico for hepatitis.
Yes, and so other disciplines have taken it in. But it's a great model to provide that training and just help people, recognize the importance of this. So
we have 2 of those in Missouri. One for the transitional youth from age 16 all the way to 25, and then we have another one for adults. And that has been very successful in educating the community.
Tell me about the transitional youth program, and let's just talk about why is that a different age or a difficult age period?
One, it is the adolescence period, the hormonal changes.
Just in general, that's challenging.
It's challenging. And second thing is also you're trying to navigate between 2 systems of care. You have the children's system of care, and then you have the adult system of care. And many states, they are siloed into 2 different agencies. So many times you're trying to kind of find common resources between these 2 agencies that people in the transitional years need in order to transition from teenagers to adults. And that also needs a lot of skill building. Resources, how do we build more resources to live independently? So there are some very specific needs that individuals in transitional age need.
Yeah, tell me if this is your experience as well. One thing I've seen, children or pediatricians tend to have a better understanding of intellectual disabilities, more experience with it. Many of them have received some training in developmental pediatrics, or I think it's a requirement for a residency. But most adult physicians have not. So when the person is older and should be, finding an adult physician, it can be really challenging to find an adult clinician who has had any training or background in this field. Is that something you've
100%.
recognized as well? Yeah.
So what we see is that there are centers of excellence for autism and intellectual disability with most universities. But it's more for the pediatric population.
Yes.
They age out at age 21. So we see that families are able to take care of these children while they're growing up till the age of 21, and this intensive services drops at age 21. And there's nothing available. Then the families struggle between age 21, 22, 23, 24, 25 by taking to the different hospitals, different ER, it goes on. And finally, they are no longer able to take care of them.
Yeah.
So they become institutionalized at that point. And that is a period of time we really need more intervention services developed so families can continue to be involved and continue to provide the services, which currently there is a lag between, and that's why the transitional age period is very important to identify the needs of transition from one to another, much earlier,
rather than later.
Much later,
yeah, than planned
because
for.
then often it is too late.
You said something that I think we're talking a lot more about, hearing a lot more about, and that's the cost. Well, what you were alluding to is people maybe go to ERs. The families they lose access to a clinician who knew them when they were younger, so they often rely on going to ERs for care, and often later than they should, which makes it more challenging, more likely to be hospitalized, and all of those things relate to the cost of health care. So if we can build systems like you mentioned that are more integrated, that where people you plan earlier for that transition period, and you have clinicians that are trained to be able to provide that health care as people become adults, you can reduce what I would consider preventable emergency room visits and preventable hospitalizations, which saves money.
Absolutely.
Yeah.
So in Missouri, based on that, we developed a home-based psychiatric intervention services. We call it the Developmental Disabilities Psychiatric Stabilization Services, which is home-based. So what we do is a more proactive system of care. We are able to identify, using our data, individuals with high psych needs. Mm-hmm. And the way we identified individuals with high psychiatric needs was based on number of hospitalizations within one calendar year, 3 or more, or ER visits, more than 3 ER visits within a calendar year, and law enforcement engagement.
Involvement.
And there's one more, that is how many placements they've had within the last 2 to 3 years due to behavioral issues. So we're able to get this data, and by identifying these individuals ahead, and while they're not in acute crisis, and going in, seeing them and treating them in-house. And we found that they were not stable. And really taking over their care. So I have a nurse practitioner, I have a couple of nurse practitioners who go into the home and I'm the supervising psychiatrist, and treat them. And we have found, and the program started about 2 years ago, and we've treated about 200 clients so far, or who have been under the care. The hospitalizations have definitely dropped. The ER visits have dropped. We are the agencies, the provider agencies, are able to retain these patients, so they're not moving from place to place to place, which actually adds so much trauma to an individual.
Yes. First and foremost, the person benefits from
Yes.
having those preventive measures put into place and having their health conditions and mental health conditions treated more appropriately. And then the secondary benefit is it's, again, less costly to prevent these things or treat them, more effectively than to wait until a person is in crisis.
Absolutely.
And,
so we've been able to prevent crisis, but does it happen? Yes, it still happens. You cannot 100%.
Right.
But our hospitalization numbers or boarding in the numbers when we started the program in January of 2024 used to be 60. At any one cross-section day in Missouri, there'll be at least 60 individuals who are boarded in the ER or in the hospital.
Wow.
Today, it is about between 12 and 15.
That is, 75% or more reduction. That's impressive.
And that is because if you really look at it, Craig, is that, yes, that is, let's say we are having a population of 1,000. I'm just giving you an example here. 1,000 individuals. And let's say 50% of them have a mental illness. So that's 500. Of these, maybe about 10% is who would actually have a serious mental illness.
Okay.
Like psychosis, bipolar, 10 to 20%. Psychosis, bipolar, all these kind of schizophrenia, really serious mental illness is about 10 to 20% of this population.
Okay.
So you're looking at about 100 individuals out of 1,000 or less. You're looking about between 50 to 100 for 1,000 population that truly have this very serious behavioral issues due to their mental illness. And if you can identify this population proactively and wrap around psychiatric services and therapy services and whatever they need, maybe many of them have trauma.
Sure.
Unmanaged trauma is a big part of this population. And you provide all the services that they need wrap around, they're going to live much better lives.
Yes, indeed.
And we know that for a bipolar individual with bipolar disorder or serious depression or psychosis, every new episode of psychosis or a manic episode or a depressive episode is inflammation of the brain, killing brain cells.
Wow.
Which is actually leading to worse outcomes.
Sure.
Decreasing the level of functioning. So it's really proactive. And the goal or the vision is that we prevent future episodes of a psychotic episode or a manic episode or a depressive episode. And when you do that proactively, the amount of medication you use is not very high. It is optimized.
And that's, another big topic in this field is using high doses or lots of different medications. And so if you can effectively manage someone, their mental health conditions better with lower doses of medicines, many of the medicines, as you mentioned earlier, cause constipation problems or can make swallowing more challenging, which can increase the risk of aspiration. So again, all of these things are very interrelated, and sometimes it really is a relatively small thing that you might have to do or implement that can have a huge impact on that person's overall life.
Absolutely.
Yeah. So great. I love hearing these things. The other thing I know that Missouri is kind of a leader in is health homes.
That is correct.
For people with intellectual disabilities. Can you talk about that a little?
Certainly. So we do know that people with intellectual disabilities, the wiring of the brain doesn't just affect the brain, it affects all our neurological systems. Sure. That means our gut, our blood vessels, our heart, the lungs. I mean, there is issues with every organ in the body that people with intellectual disability have higher rates of medical conditions that neurotypical individuals do not have. And it's important that we identify that proactively much earlier by using HERST or any tool that allows you to identify systematically,
objectively, yes.
Systematically, early identification.
Preventive, proactive.
Preventive and proactive, and intervene. Their life expectancy, not just life expectancy, the health span increases as well.
Yeah, the quality of the life as well.
Much important, because I think we focus so much on lifespan, we forget health span. Health span is so important. Every time we prevent a seizure from happening, that preserves so many nerve cells.
Yes, indeed.
And every time the person has a seizure, they're losing brain cells, leading them to early dementia, losing quality of life. It is just that these are all signs in our brain that says, the best way to prevent deterioration of the brain is to prevent these episodes from happening.
And so the health home model, is it focusing more on prevention?
It's focusing on early prevention, early identification, early intervention.
Makes sense all the way around. I would guess, gosh, there's so many things that you've said. If people want to learn more, for instance, about the health home model or some of the other things you've implemented, is there a specific website that would be the best place for them to go?
100%. So Missouri, if you look at their health home, we are the home of the health home.
Okay.
we actually started a health home with the behavioral health home, where we took up people 10 years ago. My predecessor, Dr. Joe Parks, was a champion for that program, where he looked at people with serious mental illness and found that their life expectancy was like 20, 25 years less than those without mental illness. And then he said, we treat the mental illness, but we're losing them to medical conditions. They're dying of heart attack and other chronic medical conditions. So we started proactively monitoring metabolic screening and managing, and our life, even within 12 years, we've found, I think it was 12 years increase in life expectancy already. So that program has been amazing. So DD Health Home is modeled on it, but the issues that we have are different.
Yes.
It's the gastrointestinal system, the neurological system, the seizures, the cardiac, the valve issues, the congestive heart, the congenital heart disease issues, the breathing. They don't have very good lung capacity.
Yep. And like you said, it related to all of these things. Every time you have pneumonia, a case of pneumonia, you're damaging lung tissue and getting scar tissue, which reduces capacity in the future. All of these things are very interrelated, and prevention, or like you said, early identification and prevention is the key.
Swallowing, aspiration, if you can prevent how many aspiration, we lose so many individuals with intellectual disability to aspiration pneumonia every year, choking and aspiration pneumonia. But if you know it early enough, you train them, you train staff, you identify the way to organize the food, and develop some behavioral habits that prevent choking and also prevent aspiration. You help work on, with speech therapy. There's so much you can do.
And that goes beyond just training healthcare providers, which we've talked a lot about. We need to train all supporters. Anyone who works with people or helps support people with intellectual and developmental disabilities need to understand, at least how to recognize early signs of aspiration. What do we look at? What do we see? They're the first line. They know the person the best, so they need to be able to recognize. every time this person eats lately, they've been coughing.
Yes.
What's going on with that? And they don't necessarily need to know the whole, cascade of treatment respiration,
No.
but they need to understand that that could be a sign of a person that's going to aspirate and have a really bad outcome. I need to bring the healthcare team into play.
Absolutely.
So training is key for all levels of supporters.
That's
Yep.
correct.
So this has been great. I'd love hearing all of the things that you've implemented, that your teams have implemented, and the positive benefits from that. I'm Dr. Craig Escude, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support. What would you say are three words of wisdom, three things that you want everybody to know about that you think can improve healthcare for people with intellectual and developmental disabilities?
Let me talk about from the mental health perspective, because
Sure.
you've spoken a lot
Perfect.
from the medical perspective, and as a psychiatrist, I would use this opportunity to talk from the mental health
Absolutely.
perspective. Is not to forget and to remember that 49% of individuals with intellectual disability and autism spectrum disorder have a co-occurring mental health condition, and not to label them as behaviors, challenging behaviors. It's so important that we identify, diagnose, and treat. They're very treatable conditions with amazing outcome. Their outcome is just as good as anyone with neurotypical with a mental health condition.
That's worth repeating, frankly, because I think a lot of people have a misperception that, you can do stuff, but it's really not going to have that much of an impact.
It has an amazing impact. Often I find, in our 200 individual that we do home-based psychiatric services, the most challenging behaviors, or the patients who have improved the most, are those who had undiagnosed psychotic symptoms, because they're nonverbal, and they were on antipsychotic medications. Don't get me wrong; they were on dusting of 2 or 3 antipsychotic medication, but nobody took them the time to optimize at least one of those medications and get those symptoms under control. So it's so important to remember when you see an individual with intellectual disability and they are engaging in distressing behaviors. Of course, we need to rule out medical conditions, but after you rule out the medical conditions, to think, does this person also does they have a co-occurring psychiatric condition? And it could be depression, anxiety. These are more common.
And even if they do, and you recognize that, make sure the treatment is optimal.
The treatment is optimal.
Yeah.
And they respond just as well as a neurotypical person responds to treatment. And I'm just not talking about medications alone. Medications work. They respond to art therapy. They respond to exercise. They respond to spending time doing fun activities. They respond to breathing, deep breathing.
Yeah.
Everything that we respond to, they respond to as well.
Yeah.
They are the same as us. There's no difference. And there's no difference between a neurotypical person and someone with intellectual disability in how they respond to treatment, if the treatment is provided in a way that they can receive it.
That makes sense, and it's very encouraging, frankly, to hear that and hear about the experiences and the true benefits that can come from again finding the right treatment, identifying the right condition first of all, and then treating it appropriately. So, all right, that was number one. Remember that 49% of people with intellectual disabilities have a mental health condition. All right, number one. Number two.
Number two, trauma. More than 70% of individuals with intellectual disability have gone through traumatic experiences. And this is what I want to say. When we think about trauma, we think about it from a neurotypical perspective. even among us, what you see as trauma and what I may see as trauma on a same experience is different.
Mm-hmm.
Trauma is an experience, not an event. That is a very important distinction. Trauma is an experience, not an event. And when we start looking at trauma as events, we miss the experience. So we need to look at trauma from the lens of the individual. For example, losing a staff member who's just with them for, say, last 2-3 years, and that staff member leaves. There's no time to say goodbye. There's no time for transition. For this individual, that is a traumatic experience.
Very much so. I mean, and again, we have someone in our life, and all of a sudden they're gone. You're like, what happened? Where are they? What's going on? And you can recognize that as trauma, but it's things that I don't think most of us think about.
That is correct. So that is trauma. And also, now, I'm also going to talk about events that are traumatic, which we would all consider traumatic. And that would be, for example, individuals with intellectual disability are often victims of sexual abuse.
Yes, at higher rates.
At much higher rates. Yeah. There are several reasons for that. Individuals with, I used to work in the sex offender field with perpetrators of sexual offenses, and they choose victims with intellectual disability, particularly because the chances of them getting reported is very low. Mm-hmm. And number two, it's very hard to prove in the court of law.
So they're consciously choosing people that they think will
meet their needs without consequences.
With lower risk, for them.
Of consequences. So they are very high risk of sexual abuse, physical abuse. And again, you see this a lot when children, as a way of communication, even when they're younger, they cry a lot or engaging in disruptive behaviors like headbanging or throwing things because they're not understood. And the parents, many often they respond with physical violence. Physical violence, getting locked up in a dark closet. There's always punitive strategies that are implemented.
Which is certainly trauma as well.
Very traumatic. Yes, so there's a lot of traumatic experience. And then think about those then escalate towards how many placements do they have before they turn age 18? Mm-hmm. How many foster home placements? How many residential placements? And for me, number of placements is a proxy for trauma experiences.
Sure.
And so trauma is a very important piece of this, and we need to look at them through their trauma lens and not through our objective lens.
As an aside, with you being in this field, do you think that this field is beginning to better recognize the effects of trauma?
I do.
Because I've seen more conversations, I've seen more training out there on it. I've had more requests for training and talks about it. So much so that one of the things we recently released as a company is a trauma-informed care for people with IDD e-learning course with Dr. Karen Harvey, who's one of the leaders in this field. That's if we recognize it, we need to help people learn more about it. So they educate. That goes back to education and helping people understand this.
Education and also developing a culture of a trauma-informed approach across the state. It is so important. You presume people have had trauma in their response, then ignore and that's what you presume. This person's life is characterized by these many movements.
Just to add to this in a perspective of trauma that we may not always recognize, there's a story that Dr. Harvey talks about. So you may have a person who eats in a way that increases their risk for aspiration. They may eat very, very fast. And maybe they grew up in an environment such as an institutional setting, and they had a very short time to eat, or maybe the person sitting next to them would take their food. So they learned that if they were going to get enough food, they had to eat super, super fast.
Exactly.
And recognizing that history is
very important.
So important to understanding what's going on and figuring out how can we address this better and help this person feel safe and recognize, okay, your food is not going to be taken from you by someone anymore, or whatever it might be. But if we never look at it that way, it's easy for supporters to just become frustrated or just say, you need to stop that, or whatever it is. But when you understand the root
they're
cause,
coming from,
yes.
And then you can make those accommodations, because neglect, scarcity of food and resources is a big part of intellectual disability. And the thing that I'm glad we're talking about trauma more, because for a long time, people thought that people with intellectual disability really cannot have that emotional experience.
Yes.
I mean, it is unbelievable how we could even think that these are humans.
Well, what you just said is why. Because honestly, for many years, we didn't see people with intellectual disabilities as people. We saw them as a diagnosis or
less than
just something that, we just have to deal with this and there's no hope. Yeah.
And I think the fact that we are now paying attention to the emotional aspects of them and not the behavioral aspects of them, of intellectual disability. There's the emotional aspect of intellectual disability, which is connected to the behavioral aspect of individual intellectual disability. But we focus so long on the behaviors that we ignored the emotions.
Yeah.
And it's time we focus on the emotions.
High five. I agree.
So that's my second point.
All right. What's number 3?
The third thing is that it's so important that we have a vision of what people with intellectual life should look like. It should not be any different than my life, what I look forward to. They want the same things that I want.
Right.
You know?
Want opportunities, they want interaction, they want relationships, they want to have some degree of positive control over their lives and what happens to them. And guess what? It's the same things.
It's the same thing that I want, and we want. So many times when I treat patients, obviously they come for difficult behaviors and aggression. That's how because of the home-based psychiatric service. And usually within a month, the behaviors come down, and at least within 6 weeks, we see a change. And the next question I ask them is, yes, I've treated this individual, and your life is better because your staff now, your staff are able to come to work. Right. Your life is better. Now show me how the client's life is better. Yeah. That is my yardstick to know that my intervention has made a difference. Yeah. That is my yardstick. Show me how my client's life is better. Show me that they're having a fun day. They have meaningful activities filling their day. They're not sitting bored, locked up, pacing.
Yeah.
They get to do fun things. They're joyful.
And live a life that they love.
And live a life.
I love that phrase. I heard it years back, and I just think it's a great phrase. We want to live a life that we love. Everyone does, including people with intellectual disabilities.
And that, to me, is the final outcome, and that is the vision. And all these are steps we build to get to that final the final destination, which is fulfilling, joyful life.
Well, it is clear that your work does that and facilitates that. I love the passion that you have, the insights that you've shared with everyone. It's enlightened me, and I know it's enlightened a lot of people as well. I really am so appreciative that you took the time to talk with me today and share the great work that you're doing and what Missouri is doing. And again, if you want to learn more, I guess maybe start off with the website, the Missouri Department of Mental Health website. Just thank you so much, Angeline, for joining me today, talking with me, and can't wait to hear what happens in the future and what's the next thing.
Thank you for the opportunity, Greg.
The IDD Health Matters podcast is a production of Intellectability. Learn more about our health risk reduction tools and training for supporters of people with IDD by visiting replacingrisk.com.